Good day, everyone. My name is Dr. Vince Berkeley, and I will be serving as moderator for today's rounds. Before we begin our session, I would like to thank you for joining our rounds and remind you to feel free to ask questions during the sessions in the question and answer feature as part of this webinar. Arizona Community Rounds are co-hosted by the NARBA Institute and Blue Cross Blue Shield of Arizona. Recordings of these are available at the NARBA Institute website. Today's session is entitled Transforming Mental Health Service Delivery, a conversation with Dr. Tom Insel. I'm pleased to be joined by Ms. Mary Jo Gregory, who is President and CEO of the NARBA Institute, and by Dr. Kara Christ, who is the Chief Medical Officer of Blue Cross Blue Shield of Arizona. I'll now take a moment to introduce Dr. Insel. He is a psychiatrist as well as a neuroscientist, and he has been a national leader in mental health research, policy, and technology. He has served as director of the National Institute of Mental Health and more recently, he had the mental health team at Verily, co-founded MindStrong Health, which is a startup tool for using tools for people with serious mental illness. And he served as a special advisor to California Governor Gavin Newsom. He really has focused his entire life on behavioral health issues. He's a founder of many things, including Humanist Care, and that's a therapeutic online community for recovery. In 2022, he joined Vanna Health as a co-founder and executive chair. That is a startup helping people with serious mental illness engage in psychosocial supportive care. He currently serves on the boards of Fountain House, and the Steinberg Institute. He's also been an advisor to several mental health startups. He is the author of Healing, Our Path from Mental Illness to Mental Health. Dr. Insel is a member of the National Academy of Medicine and has served numerous national and international awards, which he has received, including honorary degrees in the US and Europe. We're going to have Dr. Insel make a few remarks, and then we'll have our panelists, our two panelists, Dr. Kara Christ and Ms. Gregory, involved. Dr. Insel, please.
Well, thanks so much, Dr. Berkeley, for that introduction. And I really appreciate being able to join you for this Grand Rounds. This is a remarkable time in so many ways. Yesterday was World Mental Health Day. We also find ourselves in the middle of now two new wars that weren't around 2 years ago, and lots of things that seem to be driving Americans apart. But this is one area where I think there is some real consensus that we have a mental health crisis in the United States. Not only is that recognized by the White House and the Surgeon General, but in a recent poll that the Kaiser Family Foundation did, that 90% of their respondents felt that in this period coming out of the pandemic, that the biggest public health issue was behavioral health or mental health and substance use disorder. So it's timely and it's important, and this has happened on our watch. And what I'd like to do just for a few minutes to set the stage is to talk about some of the solutions and what we can do that can resolve the crisis. I guess the first thing to say is that I don't think it's just I think it's a trifecta. It's more than one crisis. It's probably three. And one of them is certainly the youth mental health crisis. Another is the crisis of serious mental illness. And finally, there's obviously the substance use disorder crisis. And all of them are driving morbidity and mortality into places where we've never been before. I'll just say a little bit about each one because they're somewhat different. Even though they overlap and they have some common drivers, there are also some distinctive features. And I think as we look at solutions, we want to be able to focus on these three different aspects because they do require somewhat different approaches. Youth mental health as a crisis, largely it seems to be in young women more than young men. It seems to be particularly intense for some specific focal groups, kids who've been in foster care, certainly kids who identify as LGBTQ. They have a 5.5-fold higher rate of suicide attempts. We've got about a 52.2% overall increase in suicide mortality since 2001 in this population. So this is a real deal, and it's an issue that is affecting this population in some ways more. I would say that, coming out of COVID, especially more than others. When you look at COVID, there were about 1.1 million deaths overall. Most of those actually were in people over the age of 65. About 260 deaths for people under the age of 30, which is real. But in that same period of time, that same age group, people under 30, had about 140 to 150,000 deaths from suicide, drug overdoses, and some alcohol-related deaths. So it's a stunning problem for youth that I think now really is told by these mortality numbers, which are, as I said, unprecedented. The second bucket of the three, the serious mental illness problem, is a little different. That's not actually a huge increase in prevalence. That's really more a function of what I'll call a care crisis, that we no longer provide the kinds of supports that people with serious mental illness need. We've shifted this into the criminal justice system. It's playing out in homelessness. It's playing out in all these other arenas, not in healthcare as much. And in fact, when you look at healthcare, what you see is that people with serious mental illness may be some of the most expensive patients in the healthcare system. And this is true in Arizona. We've looked at the numbers in Maricopa County. It's really striking that, about 40% of the most expensive patients on and I think this is Blue Cross Blue Shield data, are people who have a serious mental illness. This is like looking total cost of care, medical, surgical, and behavioral. So SMI, serious mental illness, is a big issue, even economically, as well as the fact that the outcomes are so dire. We're spending a lot of money and we're not getting a return on that investment. In fact, by almost any measure, there is more homelessness, more unemployment, more incarceration, and earlier deaths. Now with predictions, well, the current data would say that it's about 20 years of early mortality. People with serious mental illness are dying in their 50s and early 60s. The third bucket there is the substance use disorder problem. And here I think as well as I do that, again, there is an increase in prevalence, but the real driver is the development and the advent of these highly lethal drugs like fentanyl. As somebody said to me a few months ago, the era of recreational drug use is over because you can die on your very first use of an opiate if it's laced with fentanyl. So this really has more to do with the lethality of the drugs that are out there than with the prevalence per se, although it's significant. We're in this uncharted territory. Over 100,000 overdose deaths last year, which in any other time in our history would have been what we would call a pandemic. It would have been, if we weren't in the shadow of COVID, this would be an extraordinary set of numbers to be thinking about. So from the standpoint of mortality and morbidity, we do have a crisis, or we have these three different buckets. What I'd love to chat about in our conversation is the solutions, because there really are a lot. And I think in contrast to COVID, where we started without having a diagnostic test or a therapeutic or a vaccine, here we've got a lot to work with, and we've got decades of experience. And as I mentioned in the book, the real tragedy of the mental health crisis isn't just that the outcomes are so bad, but the outcomes are so bad, but we have so much to offer when the interventions are actually pretty good and should be very effective if given in the right way, at the right time, in the right dose, to the right person. And so the real challenge here is not a research challenge, it's an implementation challenge. It's figuring out how do we change the care system to be able to bend the curve on morbidity and mortality. And what I struggled with this when I wrote the book. It was really to try to figure out why, with so much progress in science and so many good interventions, and now spending so much money, were the outcomes still so bad? Like, why are we failing in so many ways? And I spent a lot of time traveling the country, actually traveling the world, went to places in Europe and elsewhere to try to understand what's working, what isn't working. I spent a year as kind of the eyes and ears for Governor Newsom, traveling around California, talking to a lot of people, spent time in jails and prisons and homeless shelters, lots of places to try to understand why have we failed. And I got lots of answers, but I think one of the things that really struck me was hearing from a psychiatrist working on Skid Row in Los Angeles, a really, really inspiring guy, who said, the reason we failed is we're using the wrong model. We're treating these disorders like they were infectious diseases for which, if you just understand the bug and you find the right drug, the disease will go away. And he said, that's really kind of magical thinking. That's not what these disorders are about. Yes, you need medication. You need a bunch of things. But what you really need is a much more comprehensive approach, what he called a recovery approach. And when I asked him about that, he said, well, recovery is really not that complicated. It's just the 3 Ps. It's people, place, and purpose. It's social support. It's having an environment that's supportive and nurturing. And it's having a purpose, having a mission, having some reason to recover, whether that's because you want to get back with your family, or you want to get a job, or you want to help others who have the same problem as a peer. I mean, there's just lots of ways to define purpose, but it's critical to have all 3 of those Ps. And that was really for me a kind of special moment, because I began to realize that with all that we're doing, we're not doing that. We are trying to make sure that we have better crisis services, and we're trying to make sure that we have more beds available and that more people are getting more medication. But we aren't really using our $4.3 trillion healthcare budget to make sure people have people, place, and purpose. So what I think I didn't understand when I wrote the book, and what I've come to understand in the year afterwards, is that there was a 4th P that was really critical to get the other 3, and that was payment. And we have to figure out a new payment model if we want to be able to ensure that people really do recover, and we want to start to bend the curve. And that means actually beginning to find ways to pay for the things that do work, like ACT teams and clubhouses and resource groups and family engagement and supportive housing and supported employment and all these things. It's not one, but it's a whole wheel of about 7 or 8 interventions that we know are really critical. And if they're all given along with good medical care, some of the most disabled, sickest people can actually recover and help others to recover, which is kind of stunning. And as I looked at this, I realized, this isn't that expensive. A clubhouse, about 2 weeks in a clubhouse, or a year in a clubhouse, is about the same as 2 weeks in an inpatient unit. Or even less, actually. So it's not that difficult in terms of dollars. It simply means we change our priorities, and we figure out ways to use Medicaid in new ways. We find ways that commercial insurance can make these investments upstream and ensure that people don't have to become the most expensive patients on the medical surgical service, because you're actually dealing with their diabetes and their cardiovascular and pulmonary problems before they require an inpatient stay or an ER visit. So I actually am really pretty hopeful, because I think this isn't that hard to do. It actually saves money. It gives you better outcomes. But it does require changing the model. It does require changing what we do. And I'm not sure it's the fix for all three of those crises, but it certainly could be the fix for the SMI bucket, which is one that has the most to do with the failure to care. And it's a place where I think we can really begin to implement pretty quickly. I'll finish by saying that when I wrote the book, these were all ideas that I didn't think anybody would bother to listen to or would even take seriously, because it does require this kind of profound shift in what we do, and even redefines what we mean by healthcare. And so it's kind of blown my mind to see what's happened in the last year, the way that Medicaid has been transformed in places like California, now in New York, probably. We still don't have the final word, but that the 1115 waivers in California, as an example, allow a provider to write a prescription for all three Ps. You can write a prescription for food, for rent. You can support clubhouses through Medicaid, something that wasn't possible a year ago or 2 years ago. We've had the completely transformed role for the federal government. As you folks know, this has been always a hot potato. There was the state hospitals until 1963, and then President Kennedy said in the Community Mental Health Act, last thing he signed before he died at the last day of October of 1963, he said, when he signed it, he said, people with serious mental illness must no longer be alien to our affections or apart from our communities. And so the federal government stepped up and said, we are going to take over from the states. We will be the resource through the community mental health system for people with serious mental illness. And that went away in 1980 when President Reagan said, wait, that's not the job of the federal government. Let's just have block grants that we give to the states. And in the last 40 years, we've really struggled with states saying, well, we don't have the resources, maybe counties can do it. That's all changed in the last few months, last year, with a massive new investment from the federal government. And really, for the first time since the 1960s, the federal government stepping up and saying, no, we're not going to allow the states to fail anymore. It's time for a new federally funded model like we had in the 60s, called the Certified Community Behavioral Health Clinics, the CCBHCs, a lot like the FQHCs, except they're for anybody with serious mental illness or substance use disorder. So it captures two of our three buckets. It's open, every one of these has to be open to adults and children, so to try to affect that third bucket. And it's really focused on the three Ps, what they call whole person care. So these are clinics that will be given a pot of money through prospective funding. It's sort of not quite value-based funding, but it's not fee-for-service. It's changing the old fee-for-service model. And it's providing the funds that allow each one of these clinics to run 24/7 crisis and to be able to address basically anyone who needs care, irrespective of geography, of age, of diagnosis, as long as they have a serious mental illness or substance use disorder. $8.5 billion will be going into this program. That is, way beyond, it's far beyond what we did in the 1960s. It's the largest commitment from the federal government ever to this issue. And that, along with money going into 988, money going into youth mental health services and school mental health, is kind of put us in a whole new realm in terms of what the federal government's role here is. So I think it's a really interesting moment to talk about what are we going to do going forward? And how do we make sure we learn from the mistakes of the past? Because we made a lot of mistakes in the 60s and 70s. How do the CCBHCs become like the FQHCs, a national program that learns as it goes and collects data that gets shared? How does it use technology to scale and to ramp up care? And how does it engage people who are not in care, which is really the big challenge? So I think I'll stop there, but I really wanted to start by saying this is a remarkable moment in time. Those of us who are in the trenches may feel overwhelmed by all the things that are happening at a moment when we don't have the workforce we need and when we're asking people to do much more than they've ever done before without being able to pay them much more than we've ever paid before. So it's a hard time for people who are carrying the water, but it's a time, I think, when a lot's changing, and there's every reason to be, I think, hopeful that we can actually begin to resolve these crises as they happen. So I'll stop there. Love to get this into a conversation instead of me being up on my pedestal here. So happy to open this up to Mary Jo and Kara.
Okay, Dr. Insel, thank you so much. That was quite good. Let me just say a few words about the two panelists that we have. Mary Jo Gregory is a registered nurse. She has managed very large hospital systems from California to Massachusetts to Florida to Arizona. She's the founding director for the NARBA Institute here in Flagstaff, Arizona, and has really done a lot to promote well-being. And that's one of the pillars on which the NARBA Institute stands. Dr. Kara Christ has really represented, I think, balance for physicians because she's worked in both the private and the public sector. She was the longest serving director of the Arizona Department of Health Services, which is a cabinet level position. Did tremendous work in both the COVID response and also the opioid epidemic. She is now the chief medical officer for Arizona Blue Cross and Blue Shield. And so, Dr. Christ, I'll ask you to begin, if you would.
Sure. Thank you so much for the comments. It's very inspiring, and I think a lot of really great ideas. And I do want to get later on in the conversation to the fourth P, because obviously that's where we sit, and we would love to figure out how we can support some of those services like clubhouse models and those types of things. But in your book, we've implemented a behavioral health action plan, which is really a statewide partnership with the NARBA Institute and providers statewide to engage Arizonans in improving mental health services and behavioral health services throughout the state. And one of the things that we're looking at is reducing stigma. So you'll see a little bit later about our stigma-free Arizona pledge that we've implemented statewide. But in your book, you identified the role that families have indicated that stigma plays and is a big problem in mental health, and how illnesses can become the identities as opposed to the individual's experience. What are ways that providers who are on this call can approach to help address this with patients and families so that patients receive the care that they need and they seek the services that will ultimately benefit them?
Yeah, thanks for the question. And it's actually a surprisingly difficult one. I've really struggled, and there's a chapter in the book where I struggle with this. I don't like the word stigma. I think it's a victim word. I don't think it's an action word. I don't think it helps us. Although I'm saying that knowing that you're launching a anti-stigma campaign, but I do think we're probably better off thinking about discrimination and the way in which people with mental illness are discriminated against, not just stigmatized. The fact that, it's kind of strange that, for instance, we have this law, this IMD exclusion that doesn't allow anybody any hospital to have more than 16 beds if they want to get federal funding. So you can't use Medicaid or Medicare for inpatient mental health services in any facility that has more than 16 beds. I don't think we would do that for diabetes or cancer or heart disease. But there's an odd way in which we've decided that so much of mental health care will be carved out. And we're still doing this in Arizona, by the way. And I think the civil rights movement taught us that separate is never equal, that the carving out care means less than. I just don't think that's served us well. So I do think there's a case, whether you put it in terms of parity or in terms of exclusion, that says that this is really an issue around discrimination. It's a civil rights issue or a social justice issue, and we should address it that way. We should really create the kind of social movement that ends those sorts of discriminatory practices. Having said all that, there is this issue where I think the treatments are heavily stigmatized. Again, it's so weird to me because we wouldn't do this in any other part of medicine. One of the most effective treatments we have for depression is ECT. And yet, good luck finding that in most of the United States. And in some communities, it's actually been outlawed. One of the very, very few medical treatments that has ever been actually prohibited, even though it's the most effective treatment we have. So with an enormous evidence base to support it. So there is, I think that is a kind of, I don't know what to call it other than stigma or some sort of weird hostility towards the things that actually help here. Cara, you said, you in your comments about sort of the confusion between illness and identity, and I think that is a big part of what we're dealing with. We're in the middle of an issue here in California around how we compel treatment for people who are homeless and are not, and have a psychotic illness, but are not in treatment. And our governor has said it's not compassionate to allow them to die with their rights on. That even though the civil rights advocates have said you can't force them into care, he's saying, no, actually, you're listening to their illness and not to the individual. The individual and their family will want this person to be in care. And even though this is a progressive governor, he's taken a huge amount of fire for saying, we're going to mandate treatment for people who are homeless and untreated. They're not going to have a choice. He's created what's called the care court, which basically mandates that somebody has to be in care. And it also mandates that the counties have to provide the care that they have been providing, because these are people who aren't knocking on their door. So I think the other issue with the stigma is that we have to, at some point, address this very uncomfortable issue that we're talking about a set of illnesses that affect judgment, just the way dementia affects judgment, but it's now in young people, not in old people. And in the same way that we wouldn't allow someone who was demented to wander around naked on a busy street, because we know that it would be the only compassionate thing to do is to make sure that they're in care. We just have somehow made the decision that a 22-year-old who demonstrates the very same kind of problem, that it would somehow be infringing on their civil liberties to actually require them to be in care. And I think, in California, at least, we're finally getting to a point where people are saying, enough already. We can't confuse the individual with their illness. And if we allow them to eat out of a dumpster and live under a bridge, we're listening to the illness. We're not listening to the individual who has it. That's, I think, a huge change. And I know, at least in Phoenix and Tucson, it's a big issue dealing with homelessness there. And I do think we need to get to a point in the stigma discussion where we start to say, no, treatment is what people need. It's not a choice always when you have an illness that impairs your judgment.
Thank you. I think that's a lot to think about. And how do you incorporate that? I mean, I think that's a really good point about not allowing the illness to speak for the individual. So
yeah, it's really hard, but we do it in dementia all the time. And we do it with children all the time. We figured out how to do things that even when people say they don't want them, that we know are in their best interest. But obviously, this is not simple, and there is a slippery slope here that is going to we'll have to navigate. But doing, not doing anything, allowing people to go untreated when you have treatments that work, that doesn't feel compassionate to me.
Thank you so much for the question, Dr. Chris, and the answer and comments, Dr. Insel. Ms. Gregory, did you have a question that you might ask or comment, please?
Sure, thank you. Tom, we are doing a lot of work in Arizona, especially, and I know it's going on nationally, as it relates to well-being and health professionals, and this post-COVID crisis that we have, where we have so many people coming out of the profession, and many people who have had some kind of an emotional wounding through the pandemic, and maybe for other reasons as well. Any comments you might offer as it relates to well-being in our health professionals?
This is such a hard one. When you look at, there was a strike last week from healthcare workers at Kaiser. 75,000 people walked off the job. And when you look closely at their concerns, I mean, some of it was obviously payment and salaries, but a large part of it was what they called working conditions. And they're no different than almost any other healthcare system today. I mean, with a large number of people leaving the workforce, particularly nurses, and this strike was largely the support staff. It wasn't so much physicians, but it was phlebotomists, care managers, a lot of other people who were on the picket line. What they were saying is they're now being asked to do the work of 2 or 3 people and to work extra shifts. And often they talk about what they call moral injury. I don't know if that's the best term for it. It's an economist term, but it means that the stress they feel at not being able to provide the care that they know somebody needs, and knowing that they can't provide that care, not because they don't know how to, but because they just don't have the resources to do it. There's also a lot of concern in healthcare about things we never talked about or thought much about before, like patients being violent, and not only in the emergency room, but even in the hospital itself, which we just, we never saw that very much when I was in training or in practice. So it's a tougher, much more difficult environment to be in. It's an environment in which there are, real questions about science and expertise, and a real distrust. So I think people are thrown into a lot of stuff they never knew they'd have to deal with. But I think the driving factor here is just the shortage, the fact that we don't have the numbers. So what do you do about that? Well, you have to make sure you don't bleed anymore. So you have to stop the bleeding in any way you can. And that may require simply meeting some of the demands for more money and better working conditions. And some of these, when you look at some of these healthcare systems, particularly the payer provider ones, they actually do have the margins to do some of that. But ultimately, I think, particularly for behavioral health, the answer really comes from changing the workforce itself and beginning to rely more on peers, on coaches, on community health workers. We can do a huge amount in behavioral health remotely. And when you look at the largest mental health providers for psychotherapy, and actually for medication as well, it's companies that did not exist 5 years ago, companies that are now serving literally millions of people a year, even though they don't even have an office. They're just, all of this is remote. So there's a lot you can do here without having the brick and mortar, without having the workforce that we've had, by changing the workforce, and actually not always needing people who are credentialed, by using coaches in new ways. One of my companies, the Humanist, we had both coaches and credentialed therapists serving largely university students during the pandemic. And it was amazing to me that when we looked at quality of care, it was often the uncredentialed coaches who were providing better care, at least as rated by our members and our patients, than those people who were credentialed and had years and years of experience. I just was so surprised by that. But it's always, it reminds you that it's not just the therapy, it's the therapist that matters. And a lot of this is about being a very good listener and having empathy and having the training in some of the fundamental skills. That doesn't take a lot of time. Mary Jo, just one last thought about this, because I think, in terms of our rethinking the models, there was when I was working on the book, I studied up on this project called the Friendship Bench that was developed in Zimbabwe. So you talk about a place where there was a supply-demand problem, a country of, I think, 40 million people with 9 psychiatrists, and 8 of those psychiatrists were in Harare, the capital. So, and whereas most of the people were outside of the capital. They were really having a bit of a mental health crisis of their own. And one of the young psychiatrists who had trained in the UK said, well, we need to figure out a way to provide some psychotherapy, some psychological support for people. And so what he did is he put a bench outside of every clinic, every primary care clinic, called the Friendship Bench. And he hired elders from the community. He called them grannies. It was mostly women, to serve as essentially coaches for young women, particularly postpartum, prepartum, but young women in any situation. And the Friendship Bench would be there at the clinic for people to have someone to talk to. The grannies had been trained in basics of CBT and DBT and motivational interviewing, a training that took about 2 months. It was done remotely. So they had fundamental skills, and they also had someone that they could, who was a supervisor, again, remotely for particular issues. Ultimately, he did a big randomized clinical trial across multiple sites. It was published in JAMA in about 2017, 2018. And the results were far better than what you see with any of the clinics that we would run in the United States. It's really quite extraordinary. So my point is that we need to, get a little more creative here and think about, how do you use peers? How do you use family members? How do you use grandparents? And train up people with the basic skills to provide a lot of what our credentialed therapists have been doing. And maybe that gets us through while we train up another generation.
Thank you. I remember that portion in the book on the grannies. That was just a lovely example. You did mention postpartum, and I didn't see that in your list of the key crisis areas, but do you have any comments just on, we are seeing depression, anxiety at a higher level in postpartum women, and any comments on that?
Yeah, I think that's true across the country. It seems to be part of the overall increase in prevalence. I'm not sure what that's about, really. This one piece of it could be the isolation of women postpartum, but that I'm not sure how much that's changed. But there was a time when we had extended families and we had grandparents involved in helping with childcare. That's not so common anymore. What's driving the increase, and I'm not sure that we've really documented that yet, but wouldn't surprise me to see an increase. But what's driving it, I'm not really sure. There are some hopeful things. There's a new medication, brexanolone, which works in a completely new way for postpartum depression, now approved by the FDA. I don't think it's out yet, but that'll be interesting to see, because it does look like it's part of the solution. I do think medications matter and they're important. I just don't think they're enough. And so this is another place where creating online communities and having women support each other is enormously helpful. And, I think for healthcare systems to begin to adopt those kinds of efforts, when we launched Humanest, it was not to be part of a healthcare system. It was really just to help university students support each other. but this is now used by One Medical here in California, partly just to help the workforce to support each other. And I think people, they need a way to be able to meet and to be able to not only get help, but give help. That turns out to be highly therapeutic, really powerful. And they need to do that in a place where there's some supervision and they're following some of the guidelines of things that we know work. So there are a bunch of startups doing this kind of work. We're one of them. And I do think there's real potential to scale that kind of an effort.
Thank you, Dr. Insel. I'm going to exercise the moderator's prerogative and just let the entire group know that there are collaboratives that are working here in Arizona for since actually the pandemic. And I'm going to ask Dr. Chris to comment on the collaborative for the Chief Medical Officers or CMO collaborative. And it's about health and it's about well-being. And it's about some of the fallout from the pandemic. So Dr. Chris, would you comment on that? And then I'll ask Ms. Gregory to comment on the larger and the one focused on well-being of healthcare workers in general. Dr. Chris?
Yeah, absolutely. So yeah, during the pandemic, there was a need to bring the chief medical officers and lead clinical officers together on a routine basis to make sure that we were talking about the needs that they had, the well-being support that they had, to talk about what was going on in their hospitals and offer support, between systems if there were systems. This group is still meeting. It was led by the Arizona Department of Health Services in conjunction with all of our major systems statewide. And this group actually identified some very significant projects and programs that we were able to implement during our COVID-19 response. We had a line that all the hospitals could call to get patients transferred to the right level of care at the right time. We worked with the insurers to make sure that they had the resources and the ability to, if it was an out-of-network provider. That was one idea. But then I think the idea that Mary Jo is going to talk about, the well-being collaborative, the chief medical officers and the chief clinical officers were very worried about the impact that the pandemic and treating these very, very sick cases were having on their workforce in general. And we saw that came about very early on in the pandemic. Mary Jo, do you want to talk about it? That one's an amazing collaborative.
Sure. Yeah, I think that it does go hand in hand. What we found through the pandemic, and it speaks to your point, Tom and Kara, too, on hopefulness, sense of belonging, circles of support. But what we found was that in the crisis of the pandemic, all the competition went away and everything became very complementary. And there was this great sharing of resources, intellectual ideas, solution-based approaches. We saw that with the CMO group, and we've also seen it with the Wellbeing Collaborative, which really embraced the full breadth of healthcare professionals and where there were opportunities to help. And one of the key ideas that, there was all this expertise, and we tried to move from burnout to where there was harm and where there was wounding and how we could be very solution-based. We used a lot of the people, place, and purpose for sure in that. And Dr. Swenson and Steve Swenson and Tate Schoenfeld we hosted the conference. We had about 200 people across 80 different organizations attend. And a lot of the things were very basic: kindness in the workforce, in the workplace rather. How do we bring joy back in? And this sense of belonging really was a key component of moving forward, this effort to just help each other. You mentioned non-physician or non-trained coaches that are, just peers really, and being able to take some pressure off and carry on conversations with basics like that, all the way to deploying industry-wide or organization-wide effective approaches that were from the ground up. What is broken, what is wrong, what is working, what isn't working, and so those things have had a good, I think, a foothold and are starting to make some changes going forward. I'd be interested in your comments on how we might be able to take that, Tom, and implement that into perhaps some of the training. There's been a lot of talk about moving that paradigm from what medical schools were or what nursing schools were, moving them to another paradigm, so that those health professionals that are coming out now, who are clearly have a different framework than those of us 20, 30, 40 years ago had, and any comments you might have, any insight you might have on that.
Well, I don't have a lot, Mary Jo. I totally agree that I think this generation is different in some key ways, and they certainly have a different idea of what medicine, healthcare is. It tends to be more of a job than a career. They're very focused on work-life balance. And so these issues where suddenly they have to work far more than they signed up for because we just don't have the people. And in some areas like labor and delivery, I don't know a way around that. I just don't see how we go forward without having full coverage. So it is a little harder. And I keep going back to this idea that I think we need to think about how people want to engage care now, which is somewhat different than the way, this next generation is really looking for convenience more than quality often. They're the Amazon generation, Amazon Prime, in fact, not just Amazon, but it has to be same day delivery. And so a lot of what I think we're going to need to think about as healthcare providers is how do we meet those expectations? And that's amazing. I have to get my knee replaced sometime this next year from my lifetime of running. How stupid, but I did that. And the first available appointment was going to be in the middle of March, as of yesterday. Most people wouldn't want, that's not the Amazon way. I mean, that's not what most consumers expect today for goods and services. So I think we're going to have to, at the same time we think about how do we support our own workforce and how do we make sure the people we have don't leave to go work for Amazon or to work, in our case, in the behavioral health workforce, they're leaving to go to work for Target. Literally, we've lost a large part of our coaches in a community behavioral health to Costco and Target, which is just stunning to me. So how do we turn that around, and how do we support those people? You probably won't agree with this, but I actually think one of the answers to that question is in technology. When we look closely at, again, this is behavioral health, but when we look closely at how people are spending their time, if they're working in the community or they're working in a clinic, because of a fee-for-service system that we have, and you have to explain every minute of your time to get reimbursed, they're spending about 40% of their time explaining what they do the other 60%. We don't need to do that anymore. We've got digital scribes. We've got large language models that can take the summary of an appointment and put that immediately into multiple kinds of reports for payers and providers and family members, different languages, all of that. That is, we need to jump on that. Healthcare has been so slow to innovate and to accept the very tools that the rest of the world has figured out make a lot of our operations far more efficient. So I do think, and I'm kind of an incurable optimist here, but I do think that the advent of artificial intelligence tools like LLMs, like GPT-4 and those kinds of things, maybe not immediately, but over the next several months, will give us what we need to help us a little bit with the workforce shortage, at least where I sit. And when I look at our community-based services, we could recover most of that 40% of time spent in documentation with the push of a button. We don't need to do that. Just as another example, I advise a company called Ellipsis that does voice and speech biomarkers. So every care management meeting, interview is captured and translated with an automatically generated PHQ-9 and GAD-7 and a bunch of other measures on social determinants automatically. And, it doesn't require anybody actually asking the questions. It gets to the same numbers through voice and speech. So I think there are those kinds of things that can be done that will improve will certainly improve efficiency, might even improve quality of care going forward. But we have to be open to innovation and be willing to try out some things that, are probably not the way we've been doing things in the past.
Dr. Insel, those are, I think, especially cogent comments, particularly such that we could have another session just on that alone. We're going to unmute for a moment. There's a question from the participants, and then there are two that I'd like to get to since time is moving on and it's currently 12:52 local time. So let's go ahead and unmute, please. Go ahead with the question, if you would.
So our first question, Dr. Insel, is from Pam Cahaley, and she's the CEO of Blue Cross Blue Shield of Arizona. So Pam, do you want to go ahead and unmute?
So sorry, I was technically challenged. Thank you so much. And I actually don't have a question. And I'm sorry, I wanted to just thank all of you. This was such an enlightening discussion, and it really opens up my mind in terms of thinking how we need to approach things differently. We need to look through a completely different lens to resolve this problem. And I appreciate all of you kind of opening up that dialogue and giving us just a different perspective on how to solve this issue. So thank you so much.
Well, thank you for the comment. It certainly is appreciated. There is one question that I think Dr. Insel, if you could
jump in for a moment from Pam's comment, because one of the things I haven't talked about, I think Pam knows very well, is I'm the co-founder of a company called Vana Health. And we're really interested in working in Arizona to try to figure out how do we change the model so that with our highest cost patients in Medicaid, or even not in Medicaid, but just on the medical surgical side, because that's so much of those costs are driven by behavioral health issues. So how do we engage them differently? When we looked as an example, in Maricopa County, we found that only about 29% of the attributed lives were ever getting behavioral health care. And yet they're getting a lot of medical care, mostly through ERs and hospitalization, and sometimes very high cost support. The Avana idea is that we engage people in a very different way, and we build trust so that they begin to get the kind of care that is preemptive, so that they don't end up in the emergency room because they have the 3 Ps. They're getting people, place, and purpose. There's a clubhouse, there's a coach, there's a trusted advisor and navigator. And we're really interested in working with partners around trying to prove this out, because we think this, if we could show that this works, and we think we can, it can become a national model. And we've already spoken a lot with people at CMS. They'd love to see Medicaid increasingly moving to this kind of preemptive care where you're using coaches more than expensive clinics. So anyway, just thought I would mention that because we're so excited about being able to work with partners in Arizona.
Well, certainly one of the questions had to do with implementation science, which certainly you have comments on the book, and you mentioned that. One of the things that I believe from the pandemic is that there has been some positive, if you will, outcomes, one of which is the use of technology to support mental health services that you've described. The other is ripping the Band-Aid off what was a slowly festering scar of healthcare providers and the stresses that we all had. And change is not easy in the human condition. The only creature that likes change is a wet baby. It's so interesting that someone like Simone Biles can talk about her needs, and to have someone so prominent be able to speak about that makes it easier for, I think, the entire community. There is one question that has to do with the reluctance of medical providers in general to step forward to seek mental health services. And certainly that's been one of the things I think that has changed in the NARBA Institute, Blue Cross Blue Shield, other organizations have pushed to make changes such that in Arizona, for physicians at least, we've changed the process whereby one has to disclose. Just changing the language when licensure renewal occurs has been one of the things that was an outcome. Dr. Chris or anyone else, would you like to comment on that change?
I was going to see if Mary Jo, since she's our resident expert, but
okay, great. Go ahead, Mary Jo.
Well, as a non-physician, I was waiting for Kara because I think it started on the physician level, but I think it has made a palpable difference in many ways, certainly for those that have to disclose that they are receiving mental health support. And reluctant to do so for obvious reasons. But I think secondly, it informed the governor's office and many other policymakers about perhaps they didn't even realize that this language is in there and what harm it did. And it created another platform for transparency, which I think connects to the anti-discrimination, to take away the stigma, and all of the other things that we talked about today. So to that point, I think its influence on nursing and some of the other health professionals is well underway in Arizona. And it's been a very positive piece, I think.
Well, thank you, Mary Jo, for that. I would remind everyone as we're approaching the end of the hour that there is CME for this activity. Some slides should come up talking about that. And we will have another, coming up next will be addressing diabetes in Arizona from plan to action. That's going to be November 1st. And in addition, in December, we're going to have Dr. Dave Engelvaller from the TGen. And so we'll continue with these, and it's been our pleasure to participate. We want to thank Dr. Insel for taking the time to be with us, and to thank all of you for participating. And please let your friends, colleagues, and others who might be interested to know about the Arizona Community Grand Rounds. So if there's nothing else, we'll say thank you, and hope that you all have a great afternoon and evening.
Thank you. It's a pleasure.
Thanks, Tom.
Take care, everybody.